So I participated in the NCRI panel discussion about why we should engage in trials and what responsibility the clinician has with regards to recruitment of patients into studies. And we can all make excuses that we're all too busy, we don't have the infrastructure, we don't have this or that. But really for hospitals and trusts where there is infrastructure set up and there are trials running, then there is no excuse. It's taken my centre, me being there since 2009, so a long time to set up a whole portfolio of studies for both breast and lung cancer. And lung cancer patients specifically, I think, are often excluded from studies because perhaps they're not as well as they should be when they present with lung cancer. And there's lots of comorbidities that preclude them into studies. But as clinicians, it's really imperative for us to make this part of our bread and butter medicine, really. It shouldn't be an extra thing that we do. It should be integrated into how we see patients. So every time you think about starting a patient on a particular treatment, you should think, is there a study either in my centre or out there that I can perhaps refer the patient to and inform them of that choice? And every time they progress and you're thinking about changing treatments, again, you should have the same rationale of recruitment into studies. It is really difficult to know what's out there because there's such a plethora of studies. There's lots of platforms that can help you through the NCRI, but also ECMC, so the Experimental Cancer Medicine Centres, also now have a platform that you can access to see what studies are available. So I think it is really imperative for the clinician to empower the patient, to tell them about what's available so they can make an informed decision about recruitment to studies.